Good morning, colleagues. Thank you very much, Dr. Sirohi, for the kind invitation. And I was telling my friends that one day before such a talk, I always regret having accepted the invitation. So I'm a medical oncologist and not a statistician. So during the panel discussion, please don't ask me about exponential distributions and hazard functions, although perhaps for those two, I I could explain a little bit. So how do I? Yes. So this is for myself, and I wish to share it with you. It is generally good to be less critical of others and their work. And despite the oft repeated virtues of critical analysis and reading, the first reading of a paper should not be with the aim of finding faults. So these are some of the concepts that are related to oncology related studies. And I cannot encompass and communicate several decades worth of theory and practice in interpreting statistics in clinical trials in a 15-minute talk. So I will perhaps use some examples, give a few of my own thoughts, techniques that I have used for myself in reading papers and appreciating the statistical concepts therein. And perhaps I'll finish in good time. So probability distributions, confidence intervals, survival analysis, hazard ratio, proportional hazards, interaction, relative and absolute benefits. There are several other concepts, but of course, for lack of time, I cannot really do a comprehensive talk. So the first idea is that there is a population and there is a sample. Experimenters always use sample statistics as estimates of population parameters. And just for purpose of notation, the parameters are written with Greek letters. The sample statistics are written in Latin. So an observed value drawn from the sample or a sample is called a statistic, and the corresponding value in a population is called a parameter. We measure, analyze, and compute statistics, and then apply the results, or rather extrapolate the results as parameters. So there is also something called the sampling variability. Each time we take a random sample from a population, we are likely to get a different set of individuals, and then of course calculate a different statistic. This is called sampling variability. And if we take a lot of samples from the population, the variation from sample to sample is called the sampling distribution. And often, not always, it follows a predictable pattern. And if God is kind to the researcher, it will follow the distribution, the bell-shaped distribution that you see on your left or on your right. So there is something called the point estimate, which is, all of us are familiar with those, a single value, which could be a mean, a proportion, or a difference between two means, difference between proportions, several ratios, etc. But there is also something called the interval estimation, which is a range of values or a confidence interval. And it is shown in that picture down, that the point estimate, the margin of error to the right and the margin of error to the left is what constitutes the interval estimate or a confidence interval. And these, of course, are several common levels of confidence. And the most commonly used is what we call the 95% confidence interval. And it is nothing but the distribution of sampling statistics that lie within 1.96 times, and 1.96 is the standard normal deviate, the mean to the right, and 1.96 times to the left. And this is called the 95% confidence interval. And you can see the corresponding standard normal deviates for the 90% and the 99% intervals. So the precision or the imprecision of the estimate is indicated by the width of the interval. The wider the interval, the less the precision. And of course, the width of the interval also depends on the sample size, the variability, and the degree of confidence with which we wish to state the result. A narrow confidence interval implies high precision. Uh, so the questions that we should look at when we have a confidence interval is, does it contain a value that implies that there is no change, no effect, or has the null value? And if you are looking at a difference, the absolute difference between two quantities, does that interval include 0? And if you're looking at a ratio between two quantities, does it include unity or 1? And if that is the case, then of course one cannot exclude the null hypothesis. So let me come to survival. It is time to event analysis, and we all know that individuals enter and exit from the study at different time points, some with the event of interest and some without. Now, a point to note, which we have to remind, at least I have to remind myself again and again, is the fact that the time on the x-axis refers not to calendar years, but to the time period from study entry for each individual. And this is very important because I have to remind myself of this again and again. So the assumption in survival analysis is that all patients are similar, and those who are followed up for the entire duration of the study or for some duration of the study are similar to those who are not. In other words, stated in statistical parlance, the probability that an individual is censored is unrelated to the probability that that individual will experience an event. In other words, censoring is not informative. And the other assumption that is often made is the fact that anything that affects the hazard does show by the same proportion at all times. So let me just share some important aspects of survival curves. So the Kaplan-Meier estimate is limited to the time interval at which we have the largest observation. And you could draw a line that is parallel beyond that, but it doesn't mean anything. So here, there is this survival curve will have no meaning beyond the 84 months that are shown on the x-axis. And of course, if less than 50% of the individuals have experienced an event and the largest observation is censored, we cannot compute the median time, such as in this report from the SOLO-1 trial in ovarian cancer, and therefore one has to, in such situations, report the 2, 3, 5, or 10-year outcome. So let me talk a little bit about the hazard ratio, and there is a hazard and there is a ratio. So I looked up the definition of a ratio. It is a quantitative relation between two amounts showing the number of times one value is contained within the other. In other words, it is a numerator divided by a denominator, both having the same units. The ratio, therefore, has no units. And a hazard ratio is a ratio of two hazard rates. So, for example, the hazard rate of smokers divided by the hazard rate of non-smokers. Now, rate is a special ratio in which the dividend and the divisor are in different units. So, for example, onion at rupees 60 per kilogram, and one of our foremost bowlers at 120 kilometer per hour. You will note that these are different units, and so therefore this is a rate, and a ratio is the hazard ratio is a ratio of two hazard rates, which is, for example, deaths per unit time in smokers versus deaths per unit time in non-smokers, and therefore the ratio has no units. So let me just, this is something that I partly drew for myself. So you have two survival curves here, number one, and the corresponding hazard rate. And since the assumption in survival analysis is an exponential distribution, so I will not explain what an exponential distribution is. Essentially, it means that the hazard is constant or nearly constant over time. And you have the second survival curve and the second hazard rate. And you see the delta in survival to your right. and the ratio of the two hazard rates is what is the hazard ratio. So what are some, so, one thing that we often assume, it is sometimes not the case, but which we often assume when we read a paper, is that the hazards have to be proportional over time in the Cox model. And so, for example, the picture that you see on your right has hazards that cross each other and are distinctly non-proportional over time. And so therefore, one has to account for this in the analysis, and one needs to test for this. And when one reads a paper, one should look at the survival curves, try to deduce the hazard functions in one's brain, because hazards are not what are reported, it is survivals, and then see whether the hazards seem non-proportional and account for it. So this is a paper that we wrote very recently. This is the reinfection rate after previous infection with SARS-CoV-2 and vaccine breakthrough infections in the entire employee cohort of ACTREC. And this is in the International Journal of Infectious Diseases. And what we wanted to see was a 60-week probability of infection. And on your left is the rate of infection or reinfection or breakthrough infection broken down by sex. And on the right is the rate of reinfection broken down by age. And you can see that overall, the rate of reinfection is not different, and it is not statistically different between males and females or between older and younger individuals. But you also see that here in this cumulative function curve, the hazards do seem non-proportional both for sex and for age. And somewhere in the middle, there does seem to be a difference by both age and sex. So what we did was to game this in the model by entering an interaction term between both sex and time and age and time. And you can see here that both those terms are actually significant, which suggests that the proportionality as an assumption was not really satisfied. And now in this model, you see both sex and age are significant, such that younger individuals and females had a lower rate of infection compared to the other groups. So I would like to tell you that statistical analysis can confirm that hazards are not proportional, but it will not tell you why. And that comes from domain knowledge and other insights that some of us are blessed to have. So the other thing about hazard ratio is subgroup analysis and interaction. And very often in presentations you see, so this is again the hazard or the forest plot from the SOLO-1 trial of olaparib in ovarian cancer. And you can see these are all subgroup analysis with the corresponding point estimates and the confidence intervals shown there. But let me just talk about the subgroup defined by BRCA1, BRCA2, both or none. And you see here that the corresponding hazard ratios for BRCA1 and BRCA2. So this is the benefit of olaparib versus not in BRCA1, benefit of olaparib versus not in BRCA2. And the corresponding hazard ratios are 0.4 and 0.2. So should we conclude that olaparib is more effective in patients with BRCA2 mutation compared with BRCA1? And this is often interpreted in this manner by many of us, and I also do it sometimes. But the question here is the hazard ratio of 0.2 really significantly different from the hazard ratio of 0.4? And unless we do this by gaming this by an interaction term in the model, we cannot really claim that those two are different. And a side caveat to that is that most of our sample sizes are actually underpowered to perform such interaction analysis, but one cannot really claim that the effect of the treatment is different in the subgroups, except when really shown by such an interaction. So this is another study of ours that we published in the JCO. And this compared neoadjuvant chemotherapy and surgery versus concurrent chemoradiation in patients with cervix cancer, locally advanced cervix cancer. And for the entire result, you see that CTRT was better than neoadjuvant chemotherapy and surgery, and significantly so. But when broken down by stage, you can see that the main benefit of concurrent chemoradiation was in women with stage 2B cervix cancer and not in those with stage 1. So we put this up as an interaction analysis, and you see that the test of interaction, the interaction between stage and radiation versus surgery is significant for stage, but not for the other factors. So one could claim with some justification that perhaps radiation is definitely better than surgery in stage 2B cancer, but we are unsure about stage 1 disease. So I've taken that out for lack of time. There was another study that was published by Dr. Badwe and some of us in JCO many years ago about progesterone. And there it was a qualitative interaction. Progesterone seemed to benefit node positive patient, but there seemed to be a detriment in node negative patients. So the point estimates were on opposite side of unity, and that's a qualitative interaction. But the interaction that I just showed you for our cervix trial is a quantitative interaction in the sense that the results don't seem opposite in the subgroups. And again, let me remind everyone that statistical analysis can only confirm that there is an interaction, but the reason why the effect of the treatment seems to be different within groups is non-statistical, and we have to decipher it or try to decipher it with whatever wisdom and insight that we have. So I don't know how much time I have, 3 more minutes. So, these days we have non-inferiority trials, superiority trials, and equivalence is not so common. So this is the actual meaning of superiority. The right bound of the confidence interval or the left bound of the confidence interval is entirely to one side of unity, and that's a superiority design. And a non-inferiority design means that the right bound of the confidence interval is entirely to the left of the non-inferiority margin, and this is the non-inferiority margin here. And an equivalence means that both the right and the left bounds of the confidence interval are entirely within the equivalence margins. So this is very easy to state in this nicely drawn diagram. So let me show you the interpretation. So this is another analysis that we published recently. This is a comparison of less than 1 year of trastuzumab versus 1 year of trastuzumab in an individual patient data meta-analysis. And we showed that less than 1 year is non-inferior to 1 year of trastuzumab. But so this is how we did it. You can see that the dashed vertical line is a non-inferiority margin, which was set at 1.3 based on all the studies. And this is the diamond. And if you see, the right bound of the 95% CI is entirely to the left of 1.3, hence we claimed non-inferiority. But you also see that the left bound of the 95% confidence interval is entirely to the right of unity. So somebody could also say, I say that less than 1 year is non-inferior to 1 year, but somebody can say that 1 year is superior to less than 1 year. So it depends on the intent of the analysis and what one is trying to convey. So relative versus absolute benefit. And I must say that I'm also guilty of this on many occasions, but let me just quote from this gentleman who has written this in BMJ many years ago. Researchers and their sponsors know that selling their wares on the basis of trivial absolute differences between the study groups is an uphill struggle, and instead resort to presenting the data in terms of relative risk reductions. And he goes on to say that journals must not accept these kind of reports. But of course, there can be two opinions about relative and absolute benefit. So this is a very famous study. And you see that the hazard ratio for treatment is 0.81 with a P of 0.045. And I have actually computed the hazard rates myself from the data given in this paper. And can anybody guess which study this is? Okay, so this is the affinity trial. And this is the first report of the affinity trial. And you see the absolute difference between the two arms was actually 0.9%. It was, of course, statistically significant. And the hazard ratio is the hazard ratio that I show you here. But so there's a 19% reduction, but there's a 0.9% absolute difference in disease-free survival. So let me just skip this because I'm done. So let me, in the end, tell you about Stephen Jay Gould. And some of you know that he was a paleontologist, he was a philosopher, he was at Harvard. He was diagnosed with peritoneal mesothelioma in 1982. And the predicted median survival for such a disease at that time, and perhaps even now, is about 8 months or 10 months. And so let me quote what he said. And this is in his very famous paper called "The Median Isn't the Message." I immediately recognized that the distribution of variation about the 8-month median would almost surely be what statisticians call a right-skewed distribution. After all, the left of the distribution contains an irrevocable lower boundary of 0, but the upper or the right half can extend out for years and years. The distribution was indeed strongly right-skewed. He did this research for himself in the library of Harvard with a long tail, however small, that extended for several years above the 8-month median. I saw no reason why I shouldn't be in that small tail. And actually, he died in 2002, not of mesothelioma, but adenocarcinoma of the lung that became metastatic almost 20 years after his diagnosis of mesothelioma. So let me skip this. I have written something as an editorial in a journal that I used to be the chief editor of many years ago. And this would be an outlier now, but it was the median or nearly the median not such a long time ago. Thank you very much for your attention. Wonderful.